now we shift to the next speaker, Assistant Professor Ahmed Awad Bessar again, and the topic about geniculate artery embolization and genicular nerve ablation crossing the borders in pain intervention.
Sorry. ما هو ماسك سكرت بقى كله ماسك سكرت بقى نفس ال You know, when you are a radiologist and working in pain intervention, you have wide scope. You are not only pain physician like anesthesiologists. We are doing musculoskeletal interventions, also CT guided interventions, also embolization procedures, and we are doing embolization for pain, for musculoskeletal pain, for osteoarthritis in the knee, osteoarthritis of the shoulder, and also for hypervascular lesions like aneurysmal bone cysts or masses or metastatic lesions also. For these lectures, we are talking about genicular artery embolization and genicular nerve ablation. What the difference and what is the difference between both techniques crossing the borders in pain interventions. It's not about to do pain therapy. It's not about to do pain management. It's to attack the result and the pathology. The result, he said, this is a nerve, inflamed nerve, and we can attack the inflamed nerve like in toothache, but also like in caries in the teeth, but also we are attacking the pathology. We are doing embolization to decrease the inflammatory mediator release to the knee and to decrease the pain and to kill the nerve ending by another way, like we will discuss now. Osteoarthritis is a slowly evolving process characterized by joint pain, stiffness, and loss of range of movement. Overall, as many as 40% of those ages of over 65 years old in the community may have asymptomatic osteoarthritis in the hip and knee. We started percutaneous knee pain since 11 years by simple intra-articular injections. I started to do radiofrequency and the block of genicular nerve. Block and radiofrequency is the difference, because radiofrequency you are doing ablation of the nerve, and block you are doing only injection to the nerve to relieve pain and to relieve the terminal neuropathy since 10 years, and we did cases under fluoroscopy and ultrasound guidance. Since 7 years, we started to do CT-guided genicular nerve ablation. The third eye, the ultrasound, fluoroscopy, and CT. We have 3 eyes in radiology. Now we are approaching about more than 500 cases of nerve block and ablation of the knee. Since 3 years, I started to do my first cases of genicular artery embolization. Some of my cases, and I did about 53 cases, considered one of the largest recent cases in the world, and started 2 IRB approved clinical trials. Current non-operative treatment strategies with both non-pharmacological and pharmacological therapies traditionally aim to reduce pain, stiffness, and physical disability. Number 1, intra-articular corticosteroid. It's number 1 for intra-articular injections. And this is also the Kellgren-Lawrence grading scale. Number 2, we can inject hyaluronic acid. And number 3, we can also inject platelet-rich plasma. What is the difference? No difference. All can work. So, no statistical analysis, no significance between them in any study. No study proved that PRP, that intra-articular corticosteroid, that hyaluronic acid is better. Is the best? No, the best. And the platelet-rich plasma is injected also. Let's go to the anatomy. This is the anatomy, and we should know the anatomy of the arteries and the nerves accompanying the arteries. The lateral superior genicular artery here, can make an annotation here. This is the lateral superior genicular artery here. Arise proximal to the lateral condyle of the femur, the junction between the metaphysis and the diaphysis, and the head and the diaphysis. This is the junction where the arteries make a network crossing the distal of the femur, and the proximal to the lateral condyle of the femur deep to the tendon of the biceps femoris, and it provides superficial branch that supplies the vastus lateralis and the muscle. So in genicular artery embolization, we should avoid this branch by guarding injection to avoid muscle pain, to avoid muscle necrosis, to avoid hematoma in the muscle. Then it can make an anastomosis of the lateral inferior genicular artery. 2 of the articular branches of the common peroneal nerve accompany the superior and inferior lateral genicular arteries. to the knee. So we are attacking the nerve here, which is accompanying the superior lateral genicular artery. But we are not attacking this because there is a motor branch here, so we can't ablate. This is the first area of the nerve that can we ablate. The second, the medial superior genicular artery has two branches. The front branches supply the vastus medialis and anastomosis, the descending genicular and the medial inferior genicular arteries, and the other branches supply the knee joint and anastomosis lateral superior genicular arteries. So the medial superior make an anastomosis with the lateral superior and also make an anastomosis with the medial inferior or medial lower genicular artery. The medial inferior or medial lower genicular artery has also two branches. The first courses along the upper border of the gluteus muscle on the medial side of the knee and anastomosis descending genicular and the medial superior genicular arteries, and the second branch crosses the tibia. So this is the crossing. This is the crossing of inferior medial genicular artery, and this is the crossing when the nerve is here. So the nerve with the superior lateral genicular artery, the nerve with the superior medial genicular artery, the nerve with the inferior medial genicular artery are our targets. There are some other nerves, but this is three main nerves for attack. So this is the superior medial genicular nerve, superior lateral genicular nerve, this is the fibula here, and the inferior medial genicular nerve. But we don't ablate the inferior lateral genicular nerve. This is the first procedure, which is called genicular nerve ablation, and this is the muscles. The joint is consisting of the bone of the synovial fluid and synovial covering, synovial sac, and also with bursa, and also with bony structures like patella, and also with muscles and supporting ligaments like ACL, BCL, medial and lateral and collateral and reticular ligaments, and also with tendons. So this is the joint, and this is the knee to become osteoarthritic. This is the pain. After the pain, there is a restriction of the movement. After restriction of the movement, this is the diminish of the muscle power, and also after this is a more joint friction and more osteoarthritis. So we should cut this visual circle. The genicular nerve ablation by ablating the genicular nerves, like we talked before in the previous slide. What are the indications and the contraindications? I put this image of after total knee replacement to show you that we are treating the nerve. We are not a replacement to the total knee replacement. But if you are doing total knee replacement, the orthopedic physician should tell the patient that the pain may persist. I can make a joint function or joint alignment regain it, but the pain may present because there is a persistent inflammation of the nerve ending. So after total knee replacement, about 25 to 50 of cases considered pain, similar pain like before the procedure, and we are doing genicular nerve ablation for these patients also. Under fluoroscopic computed tomography and ultrasound, thermal RFA targets the lateral superior, medial superior, and the medial inferior genicular nerves. In fluoroscopy, we can target the nerves under bony landmark, the first. Under CT, we are targeting the nerve by relying on the bony landmark. We are relying on the bony mark, but on CT, we can also see the nerve, and also we can see the artery arising from the popliteal and the other branches. By ultrasound, we are seeing the artery and making the target of the nerve near the artery. Don't fear about arterial injury, it's good. In this studies, a significant pain relief was seen in 60% of patients after 6 months follow-up. In the previous studies, the genicular nerve innervating the knee are targeted using a landmark by fluoroscopic guidance, and also there are many other studies. We can cross this table, but I will see that we are providing 30 to 40 degree of flexion under fluoroscopy and maybe also under CT guidance. The 30 to 40 degree flexion with the pillow under the popliteal region, it make a more comfortable position for the patient and for the doctor. And we can place about 18 or 20 or 22 internally called 4 millimeter active tape. The active tape may be 2 millimeter, 5 millimeter on 1 centimeter, no difference at all. This is the first targeting you can see, and this is the targeting of the media. superior lateral genicular nerve here and here, and in the lateral view in fluoroscopy, it approaching mid shaft here. And this another one of the cases ultrasound. When we can see, we can targeting. I will video back. Yes, you can see the arteries here, and you can see this is the artery, inject near the artery, and this is the artery in cross-sectional and longitudinal view. And this is also another case. We can see, you can see the needle here, and this is the artery Doppler, and we are injecting our injected or make a radio frequency near the artery, and we are doing sensory and motor stimulation also, and this is similar. And by CT guiding technique also we can see here, this is the 3D format after a case, and this is a needle intra-articular. In some cases I'm doing also intra-articular injection of corticosteroid inside the joint space in some cases, not in all cases. This is the osteoarthritis. Sometimes by degree 4 osteoarthritis I would like to do this ablation. This is the intra-articular here. This is very safe under CT. And this also the inferior lateral genicular nerve here. And this is another case, and we can demonstrate here by this case. This is the nerve here, and you can see here, I can show you. I can show you, this is the artery. You can see this is the artery and this is the artery. You can see here, and you can detect the artery here under CT. This is the arterial branch, this is the arterial branch. We direct it toward the arterial branch and also targeting according to the bony landmark in CT. This is the intra-articular needle, and this is the last needle here. The second technique is geniculate artery embolization. The first known use of genicular artery embolization for the treatment of individuals who experience spontaneous hemarthrosis following knee arthroplasty. In a systematic review made by Milan et al., they showed that genicular artery embolization is a safe and effective modality for this purpose and other purposes like in osteoarthritis. And its work is the most important. This is the idea for genicular artery embolization, where you are doing embolization for the artery. It works by blocking the neovascular vasculature that forms as a result of knee joint degradation and inflammation, thus preventing the cycle of inflammation and the cartilage damage and sensory nerve growth. So we may reverse the osteoarthritis, we may reverse we may stop the osteoarthritis. And the main inclusion criteria included in all patients suffered from a unilateral knee pain, full all procedures performed in a floor-based cath lab machine, patient was supine and head first and legs were toward the tube. We are doing antegrade approach for the patients. And we are doing also subtraction and geography, and then by microcatheterization under root mapping, we are targeting the genicular arteries, like the video I will show you. And the success is considered justified if we make at least one of the 60 branches of the geniculate arteries supplying the region of the maximum tenderness, like the next video. And this is criteria to be measured before the treatment, like number of arteries catheterized, our checklist, height of the patient, total dose of radiation, of amount of contrast, WOMAC score, was score, Green-Lawrence classification, and assessment of local complications, and also patient satisfaction to the pain results and also to the procedure. This is a case. This is the last slide. You can see this is a catheter. It may be Cobra catheter and maybe also Berney catheter, vertebral catheter. And this is the navigation of the microcatheter inside the superior medial genicular branch. Here, this is the navigation. You can see the angle is a difficult angle. And you can see the plush here. This is the plush. And we are doing embolization, mainly by 100 micro embospheres, but in some other institutions doing glue embolization also as well. We're doing backing by ice packs to the skin to make a vasoconstriction to the skin to avoid muscle injury and inadvertent embolization to the surrounding muscles and the skin to avoid the skin discoloration. But we should tell the patient that maybe temporary skin discoloration on the knee. It is accepted also. We are finishing the video. You can see this is another branch. This is another branch also, and also this is a like intrasynovial branch, and this is the navigation process we are doing. Regarding RFA or block of the genicular nerve with or without intrasynovial injection of PRP, we can consider them an easy, rapid method to control pain. Now it's gaining much popularity with intervention radiologists, intervention pain physician, orthopedic surgeon, and rheumatologist. And regarding the geniculate artery embolization, which is considered as a promising minimally invasive therapy for the treatment of knee pain in patients with osteoarthritis, the initial results showed a statistically significant improvement in pain and function scores after the procedure with no major complications. Thank you.